Hello everyone, today we are going to talk about Ludwigs angina. Ludwigs angina is a potentially life-threatening infection. It is most commonly located in the second and third mandibular molars, causing a bilateral submandibular or sublingual space abscess, pushing the tongue up and forward. Because the tongue can obstruct the airway, the most common cause of death in these patients is asphyxiation. So whenever you're working up these patients, this is most certainly an emergency and something you need to let your attendings know you have a suspicion of as soon as possible. For history, you're going to hear reports of pain in the patient's throat, neck, or jaw, potential dysphagia, and the big red flag here should be voice changes. This is almost never something that's benign. For history, you might want to ask about recent dental infections or trips to the dentist, recent facial fractures or facial trauma, and then something that's always good to ask about in these more exotic infections is an immunocompromised state. On physical exam, your patients are going to look sick. They're going to be febrile and tachycardic and possibly trigger a sepsis workup. Now, whenever you're doing your physical exam, you're going to want to do a good HENT exam, and on that exam, you'll probably pick up elevation of the tongue. You might hear stridor whenever they're talking to you. You might see decreased range of motion in the neck. Now, things that are concerning for airway loss. These are things you cannot miss. Stridor, tachypnea, so if they're breathing hard or struggling to breathe, reporting shortness of breath. And then the big one here is drooling. If they are not able to manage their secretions, you need to leave the room and get your attending as soon as possible because they are a concern for impending airway loss. So you need to do your airway exam quickly and make sure they're okay before you proceed. So whenever you're doing your airway and HENT exam, this patient is revealing a common sign you might see known as the double tongue sign, as reported in the New England Journal of Medicine. This patient's tongue is pushed so far up and forward that it actually looks like they have two tongues. So be on the lookout for this sign. This is certainly not the only infection or problem that can cause pain or airway issues in this part of the body. So your differential should consist of dental infection, cervical node separation, peritonsillar deep neck space abscesses, angioedema, submandibular hematoma, or even malignancy. As always, your diagnostic testing should fit your differential diagnosis, and most of the things on your differential here are actually going to be clinical diagnoses, especially Ludwigs angina, where your labs should focus on working up other causes and possibly seeing if there's been any spread through the bloodstream. So working up possible sepsis or bacteremia in these patients will include getting blood cultures, possibly a CBC and other stuff like that. Now for imaging, this is where you're really going to make the diagnosis. So the gold standard is CT face and neck. I would argue that there's value in going ahead and getting a chest CT because a lot of the planes in the neck actually connect down into the chest. So if there's concern for rapid spread of infection, you also want to consider that these patients might have mediastinitis. That actually happened in a patient I was working out during my 4th year acting internship. But CT is the best at identifying the extent of the disease and looking for potential complications. Ultrasound is good because you can do it pretty quickly, and there are pretty classic signs of infection that you can pick up on ultrasound. These include swelling or signs of edema and potential gas collections within the skin. If you take away only one thing from this video, it's that this is an emergency because these patients are at risk for airway loss. So your management will begin with A in your ABCs, secure the airway. After you do your airway exam, even if things look pretty benign, you need to develop a plan for how you would secure this airway, even though as a medical student, you probably won't be the one doing it. You're going to want to present these things as part of your plan and potentially help your residents or attendings get these things ready because it'll make you look like a rock star on your rotations. So you're going to be considering advanced airway techniques. Even like direct laryngoscopy or video laryngoscopy probably isn't going to be good enough for these patients. You're probably going to be using advanced techniques like fiber optic oral or nasotracheal intubation, and you'll likely be doing an awake intubation because you don't want to take away these patients' respiratory drive and make the situation way worse for yourself. Criking these patients is definitely an option, but depending on how much their disease is spread down their neck, you're could potentially be getting into some pretty dicey situations, but if you have to do it, you have to do it, and you should always be prepared to do a surgical airway in patients who you think will have a difficult airway. Other things you're going to do, get an ENT consult. This is a must because these patients possibly need debridement, so they might be going to the OR, and these patients are in pain. That's probably why they came in. So you need to give them adequate pain control, probably with morphine 0.1 milligrams per kg, and possibly steroids. This is something you should talk over with your attending too. The hallmark of treatment in these patients is antibiotic therapy. You need to start broad spectrum antibiotics early. There are a couple different schemes you can use based on their immunocompetent versus immunocompromised status. I don't think it's super important to memorize these because this is likely going to be something you look up in the EMRA antibiotic guide or on UpToDate, or not really need to commit to memory. The big thing here is that these are polymicrobial infections, so you're most likely going to be pulling out some big gun antibiotics. Just check your local antibiogram so that you're making good decisions and being a good steward of your antibiotics. For tests, I think it's important to know that if the patient in the question stem reports a penicillin allergy, not only for Ludwigs angina, but for most things, clindamycin is a good option if they're penicillin allergic. So after you have successfully managed the patient's airway and got them started on their antibiotics, it's time for you to dispo them. The good news is for these patients, though they're pretty complex and pretty scary, the disposition isn't very hard because they're all going to get admitted. These patients are headed to the SICU for advanced airway management and IV antibiotics, or they're going to the OR for debridement with ENT. However, they're all going upstairs. So we secured the airway, got the antibiotics started, got the patient upstairs safely. It's time to review some fast facts and practice pearls. These infections can spread rapidly, either locally or through the blood, so that's why getting our CT scan to gauge how much local progression has occurred is good, and potentially getting blood cultures is a good option in these patients. Get that airway secured early, or at least have a plan to get it if needed, because these will be difficult airways, so having a good plan in place will be good even if you're not the one doing the intubating. Start antibiotics early. This is a hallmark of treatment. You need broad spectrum coverage because these are polymicrobial infections. Finally, I know I've mentioned CT a couple of times, but these patients have a potential airway obstruction, and if you make them lie flat, you need to be aware that laying flat may take away their airway, which means CT or other imaging like that will not be an option. So this is something you definitely want to try with your patient in the room if you absolutely think you need a CT scan, because you would rather them lose their airway or start to have trouble breathing while they're in a room where you have suction, oxygen, all the tools you need to intubate instead of in the CT scanner. Though you likely won't be doing much of the direct care of patients with Ludwigs angina because these are true emergencies and something you are likely not to be in the driver's seat for as a medical student, it's still good to know what's coming next and to know what the plan most likely will be so that you can help out your residents and attendings. Anything involving the airway is pretty scary, and just having a good plan in place makes those patients a little bit less daunting, at least in my opinion. So I would encourage you to read more about these. These are the resources I used, and I found them pretty helpful, so I hope you will too. As always, thanks for listening.